Welcome, everyone, and thank you for being with us today. Power to Save and the AST Community Education Committee are proud to present today's webinar, Hope, Healing, and New Life, Pregnancy After Transplant. AST and Power to Save are grateful to Eurofins for their generous support of this event. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There's currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded, and the archive will be available on the AST YouTube channel 2 to 3 business days after the live session. Please note, all of your lines have been muted so that only the presenters and panelists can be heard clearly for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by chatting to the host and panelists, or use the Q&A button in the Zoom webinar panel. Please note, questions submitted via the chat window may be missed during the presentation. So if you want your question to be considered for the Q&A, please remember to use that Q&A button for the best chance for your question to be seen. Finally, when you log off at the conclusion of today's webinar, you will see a short link to an evaluation survey. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Lisa Coscia from the Transplant Pregnancy Registry International, to begin our presentation.
Thank you so much, Brian, and welcome everybody. And on behalf of the Community Education Committee and the American Society of Transplantation, I'd like to welcome our panelists and thank all of you for attending live with us today. Today's webinar, as Brian said, Hope, Healing, and New Life, Pregnancy After Transplant, is part of our ongoing commitment to connect with the transplant community and the dedicated providers who support them. We'll begin the first half of the webinar with a pre-recorded candid conversation between myself and Joelle, a two-time transplant recipient and mom of a beautiful little boy. We invite you to stay with us. We'll transition to a live Q&A session for the second half of the program, featuring all of our panelists and including myself. And at this time, we will start our video and join back for the Q&A portion of the session.
Hello, my name is Lisa Coscia, and I'd like to welcome you to our second webinar regarding Power to Save, One Transplant for Life from the American Society of Transplantation. And on behalf of the AST Community Education Committee, I'd like to welcome Joelle with me here today. And this session will be about pregnancy after transplantation. Like I said, my name is Lisa Coscia. I'm the Senior Nurse Research Coordinator for the Transplant Pregnancy Registry International and have been studying pregnancy after transplant for about 25 years now. And I'd like to introduce Joelle.
Hi, I'm Joelle Wiedenbaum. I am a liver and kidney recipient. I received my first transplant at the age of 18 months old from my dad after being diagnosed with ARPKD, the pediatric polycystic kidney disease. I received my first transplant at 18 months and then received a liver and kidney transplant from him when I was 9 years old. Because of that life-saving gift, I've been able to live a whole life. I graduated high school and college. I went to graduate school. I'm an occupational therapist. And I met my husband and we lived in New York City and we got married. And then after that, we decided that my whole life, I've always wanted to be a mom and I've always wanted to have a family. But I didn't always know how. I didn't know if I was able to. I didn't know how pregnancy would affect my transplant. And I just always thought that it was just kind of, there weren't a lot of options or I wouldn't actually get to be a mom. So I'm very fortunate. My husband and I got married in 2019, and then in 2020, kind of towards the end of 2021, towards the end of the pandemic, or I guess we're still in it, but we were just looking to see what our options were to start a family. So I met with my OBGYN and she had said, well, let me send you to maternal fetal medicine for a consult. I'm from the Philadelphia area, so I went to a Virtua consult with Dr. Shaw at maternal fetal medicine, and he looked at my numbers, and my kidney and liver doctors looked at my numbers, and they all said there's no reason why you can't have a family. So They said, you know, surrogacy is an option. There are all these different options, but everything seemed like very daunting and expensive. And adoption seemed very expensive and just a very daunting process. So my husband and I decided to try naturally. I became pregnant in, oh my gosh, November of 2022 or 2021, excuse me, 2021. And my journey was 9 months later. I had my little boy, Wesley. He was just the most adorable little squish that I ever held. And I was so grateful. I didn't have too many complications for my actual pregnancy. I was able to stay active through the whole thing. I was getting my labs done once a month when I went for my OBGYN appointments. My labs always seemed very stable. Again, I was very active. I work a job. I work in a school. I get 12,000 steps a day. That never stopped until the very, very end when I couldn't really see my or feel my feet anymore. I'm pretty petite, so I'm 4'10". So that was a different kind of you know, being pregnant and 4'10" is a different kind of challenge. But my numbers stayed steady throughout pregnancy, and I did have juvenile or gestational diabetes that I think is genetic. My mom had that with me. And then towards the very end, I did develop preeclampsia. I recognized the symptoms right away. I was super nauseous and I had high BP, and I was induced a couple hours later once my doctors knew that that's what I had. So 39 hours and a C-section later, there's Wesley. He is just such a, like I said, such an adorable little squish. He was such a good newborn. He was born with no complications. Everything was perfect about him, and he's still just a very cute, very perfect 2.5-year-old who just keeps me running and keeps me active, and just keeps us all smiling all the time. He's so silly. He loves animals. And as for me, I am still very active. I just ran my fastest 5K ever. And 2.5 years later, and I'm, you know, my numbers, knock wood, have all been good. My medications like never really changed throughout, and they still haven't. And I just feel very, very lucky and very, very blessed to have Wesley and to have my family and to have this life that I have. And one of the things that I found super, super helpful was the transplant pregnancy registry. And especially Lisa, I know I had a consultation with a doctor when I first became pregnant that made me very, very nervous. And somebody had suggested that I reach out, and you called me immediately, and you just like really just made me feel comfortable and made me feel confident that this was the right choice and this was the right journey. So we can kind of dive into some of the questions that I shared at the time, which Dr. Shaw had shared, has talked to me, and as well as my transplant doctors. But is it possible to get pregnant after a transplant?
Absolutely. I think that was probably one of the first questions that you asked me. I think your case is a little unique because you've had the liver and kidney transplant. Most patients just have one organ, but as long as your transplant's working well, people usually get their menstrual periods back quickly right after transplant. And in fact, some pregnancies can happen very soon after transplant. So it's important if you want to plan a pregnancy to use contraception. And we can also send you information on contraception too, because there are many different options that transplant patients can have as well. So, because what we've really found is that a planned pregnancy is best because we want the mom to be in the best health, to be on the best medications for pregnancy, and just overall good health after transplant.
And then another question that's asked is, how long should I wait to get pregnant after transplant?
So it really depends on your transplant. But what we usually say is that you wait at least 1 year after your transplant. I know you were very young when you had your transplant, but a lot of our patients can have some complications in that first year after transplant. We see that's when most rejections happen. You're at more risk for infections. So we really want patients to wait at least 1 year. And I think for our lung recipients and some patients who might have some complications afterwards, they might need to wait longer as well. well. So it's really important to talk to your team, which you did. I know I hear a lot of times that patients are really nervous about talking to their transplant providers. And I think, you just have to have that honest conversation with them and know that there are resources out there for you to get and even bring with you to your appointment. The AST, this is all from a brochure that we did with the Women's Health Community of Practice, because we really want patients to have the best information available. So this is a little more specific about some testing that might need to be done. And this is where some of our other information comes from. Really, like you kind of did everything right before, thinking about becoming pregnant, because we really want people to have a planned pregnancy, like I mentioned. And we know that waiting at least a year is really ideal. And then maybe a little longer for some of our thoracic patients, because we really want to make sure that everything is working well with your transplant. So for kidney recipients, sometimes they might need a biopsy before becoming pregnant, and also for heart recipients, an echocardiogram and pulmonary function tests for our lung recipients. And we're going to get into this a little bit more about the medication, because there is one medication that with a planned pregnancy, it should be stopped beforehand. And also just thinking about if you have high blood pressure, that should be well controlled. You mentioned you got gestational diabetes during pregnancy, but some patients have are on insulin or other anti-diabetic medications before they become pregnant. So really to have all those what we call a comorbidity or other things managed really well before thinking about going into a pregnancy. And I know some of our liver patients and heart patients should have their kidneys checked, because some of the medications that we give people can affect their kidneys long term. And also thinking about, I don't know, did you have any genetic testing done before you were before you conceived?
Yes, I did. I have ARPKD, so that was something that I wanted to make sure my husband didn't have the recessive gene for, because then our kids would have a 50-50 shot of having that. So that was definitely something that we made sure that we planned for and budgeted for as well.
Oh, that's great, because we know that some of the things that cause people to need to have a transplant can be inherited in their children. So if that's the case, sometimes, having that genetic testing done before going on to having a pregnancy too. And I'm sure Dr. Shaw might have mentioned this, but we do see a higher percentage of prematurity and low birth weight in our transplant recipients compared to the general population, which I don't always think is fair, because we know that you're a little different from the general population, but that's something that we've definitely seen over time too, with our transplant recipients.
Should I take my transplant medications during pregnancy? I know that that is something that a lot of people becoming pregnant don't necessarily know. So should I continue to take my medications during pregnancy?
Yes, very much so. We need a healthy mom in order to have a good, healthy pregnancy. There is one medication that we have found causes an increase in birth defects and miscarriages, and that's Cellcept or Myfortic. So it's really important to talk to your team about switching to safer medications before you get pregnant, because a lot of times what that also entails is checking to see how your organ's working when they switch you to a different medication, because we want to make sure that you didn't need that medication for immunosuppression before you become pregnant, because we really want your transplant to be very stable and have no problems with any rejection before going into pregnancy. But overall, we have found that The generally considered safe to take during pregnancy are tacrolimus, cyclosporin, azathioprine, and steroids, or you might heard them called prednisone. We have some other medications that we give a lot of transplant patients that we just don't have as much information on, and that's sirolimus, everolimus, and belatacept. And as I mentioned, the mycophenolic acid and mycophenolate mofetil are contraindicated during pregnancy because we do see an increase in miscarriages and birth defects with those. And it's not 100% birth defect, about 20%, but we do see about 50% of miscarriages when the patient is on either mycophenolic acid or mycophenolate mofetil when they become pregnant.
So what are some of the considerations that women should have when becoming pregnant?
So I think I feel like I'm a little bit of a broken record, but we really want you to talk to your transplant team and wait that 1 year. And we want to make sure your transplanted organ is working really well. I'm sure, like you said, they looked at your liver numbers and your kidney numbers and really made sure everything was stable before giving you the green light to get pregnant. Were you on mycophenolate?
I was not. No.
Because
No.
you were younger when you had your transplant, so they probably weren't using it quite yet in kids. And also, like I mentioned, we want to make sure your blood pressure, diabetes are well controlled, and that your overall blood tests are good. Once again, reviewing those medications to make sure that you're not on mycophenolate. And also, like you mentioned too, is seeing a high risk obstetrician, because really all transplant pregnancies are considered high risk. And I always tell people that when you get pregnant, it's almost like post-transplant. You're going to start seeing your transplant doctors probably monthly, and then as you get to the end of your pregnancy, you're going to see them every 2 weeks, and then it might be every week. Kind of the opposite. Everybody's like, oh, I see my transplant team twice a year now, and not very frequently. But when you're pregnant, those visits are going to come more often because they really want to follow you to make sure the baby's growing and that you're not getting symptoms of, like you said, preeclampsia, because that is another condition that we see more often in our transplant patients. So it's something to be aware of. And also, I know we sent you our report before you became pregnant as well. So there's a lot of different resources that we can provide to patients when they're looking into pregnancy after transplant. And also just, thinking about social support too. I'm sure you know about how, being a new mom can be overwhelming, and making sure you have all of, those social supports that will help you after you have the baby as well.
Absolutely. Yeah, those are really important too, for sure.
Yep. And you probably had all these conversations with your husband and your care team as well. So it was kind of a shared decision making when you came to this.
Absolutely. Yeah, it was like putting all of the puzzle pieces together to make sure that I could have a safe and healthy Wesley. So
Oh. Yeah. And he's adorable. So that's wonderful. Can you think of any other questions that you might have had that we didn't cover today?
I think one of the ones that I was thinking about was breastfeeding after pregnancy and while on medications. I know I wasn't necessarily comfortable with it because I didn't know how, and I probably should have reached out a little bit sooner for the data. But I just breastfeeding and being on the different medications and things like that.
Yeah, so we can say that if you're on the medications that are safe to take during pregnancy, we found that patients have not had a problem breastfeeding, especially with the tacrolimus, cyclosporin, azathioprine, and prednisone. And that was based on a couple of studies, like from 2014 on, and we've seen many more people choose to breastfeed. When I started doing this a long time ago, I could never even talk about breastfeeding. I just had to say, nope, you can't do it. But now they really think that the amount of your medication that gets into the breast milk is very low. So that is something that we tell patients that they can try to do after they deliver.
Awesome. Thank you so much.
And the other thing I was going to mention too is that we really, in our studies, have not found any problems in the children long term either. So I call them some of our kids, but some of them are into their, 30s and 40s, because patients who've had their children in the 70s early on are grown now and having children of their own too. So we know that these children are going on to even have their own children, and our transplant recipients are grandparents now as well, which is so heartwarming to know that, because of an organ donor, you have not only a second generation, but a third generation as well.
Wow, that's amazing. I feel like I'm so like not far enough into the journey to really think about that yet. But even just when I think about Wesley, I think about like what an organ donor gave the world, right? And so it's kind of amazing that it can give so many generations. Wow,
Yeah.
thank you for that.
Absolutely. Yeah, no problem. Well, we want to thank everybody for their time, especially Joelle for sharing her wonderful story with us today. And what we're going to be doing is having a question and answer period next, and we'll look forward to hearing all the questions from everyone.
Welcome back, everybody. We're excited to start the question and answer period. First of all, I'm going to ask our panelists to come back on camera, and we're going to just do a brief introduction. And we had an overwhelming amount of questions asked before the webinar, so we're going to get to as many as we can. But I'd like to start with Joelle Atkinson, if you could just briefly introduce yourself.
Hey, hi, Lisa, of course. Hi, everyone. I'm a transplant infectious disease physician at University of Miami, here to help with any of the infectious disease questions that come up.
Great. Elizabeth, you're next on my screen.
Great. I'm Elizabeth Kincaid. I'm a transplant pharmacist at University Health in San Antonio, Texas.
Great. Carly Lair.
I'm Carly Lair. I'm a transplant pulmonologist at Cleveland Clinic.
And Sylvie.
I'm Sylvie Shah, a transplant nephrologist at University of Cincinnati.
Great. So I'm going to ask Joelle to hop back on to start with, because I think we were talking ahead of time a little bit, because I think some of my other questions were answered. So you did follow with a high-risk obstetrician during your pregnancy, correct?
Yes, I did. I was with Capitol Health here in the Central Jersey area. I'm out in Bucks County, and I saw their maternal fetal medicine doctor.
And did they have you take any special vitamins during your pregnancy, or anything above like a prenatal or outside of a prenatal vitamin?
I think I had labs drawn, and that I might have been like low magnesium at one point, so I did have to take additional magnesium, but it was because I was monitored so frequently that they were able to make those adjustments as they needed.
Great. And like I said, we were talking a little bit ahead of time, and one of the questions was kind of balancing being a transplant patient and a parent, which I think, being a brand new parent is hard enough as it is, and then you have another layer. Just talk a little bit about your experience transitioning, into having a baby after your transplant.
Yeah, absolutely. So it's affected my life in so many ways that I didn't necessarily know that it would have. But definitely, like, I've always been very health conscious, very making sure that I can eat right and work out every day. And like, as a new mom with a new baby, like, your time is very much limited. And especially when I went back to work, my time was a lot more limited. I work in a school, so I am fortunate to be off in the summer, but for the most part, I'm running around all day, picking him up from daycare, dropping off. He's up early in the morning. So it's yeah, even still at the age of 3, he's up very early. But especially one of the things that I never really thought about was when I sent him to daycare, he would get very
he would get sick, like as they do when they start daycare. And we joke in my family that like Wesley will get sick for a week, my husband will get sick for a day, and I'll get sick for a month. So it's really trying to balance it and making sure that like when he's sick, like I keep my distance as much as I can, as I can, of course. But just trying to balance all of the different things in ways that I never really thought about before I was a mom. So yeah, just trying to keep all the balances in
I
check.
think that happens with all of us, but there's just a little bit added for our transplant recipients to think about. Elizabeth, I'm just going to ask you a little bit as a pharmacist. Can you briefly give recommendations for transitioning off of mycophenolate if someone does come to you who would like to conceive?
Yes, absolutely. So if somebody needs to be transitioned off mycophenolate, our anti-metabolite agent of choice that is safe during pregnancy would be azathioprine. What I like to do in practice, if I know might switch somebody to azathioprine, and if we have time on our hands, we could send pharmacogenomic testing for TPNT and NUD15 for a genotypic phenotypic test to really make sure that azathioprine is safe for a transplant recipient and they can metabolize it okay with those enzymes. And then once we switch them, the mycophenolate is a twice daily medication. The patient can just finish off that nighttime dose and then take the azathioprine as prescribed by their transplant provider the next morning. The azathioprine is a once daily drug, so it's easier on the patient. And then really what we're looking for is that 6-week washout period before trying to conceive, washout of the mycophenolate. So in the meantime, the transplant provider will likely be checking their graft function, their organ function to make sure it's stable on the new medication, azathioprine, monitoring CBCs, especially if we don't do any additional genetic testing to make sure that they're tolerating it okay.
And do you have any specific recommendations for when to restart the mycophenolate after the pregnancy?
Yeah, definitely. I think that really depends on if the mother is planning to breastfeed. If she is planning to breastfeed, the safest option would be to stay on azathioprine. We know it's lactation compatible and it is only absorbed through the breast milk less than 1%. So just because there's so many teratogenic risks with mycophenolate, we really would want to avoid that while breastfeeding. But if the transplant recipient does want to do formula feeding, they could be switched back the same method, finish the azathioprine, start the mycophenolate at the intended dose the very next day. There doesn't need to be any sort of overlap of the two medications.
Wonderful. And I think we had a few questions just about fathers. And are there any recommendations regarding fathering a pregnancy on mycophenolate?
So I'll give you the package insert answer. So the FDA, and then I'll give you my other answer. So the FDA does include within the mycophenolate package insert that males taking mycophenolate should use contraceptive measures while taking it and for 90 days post, just out of an abundance of caution, not having definite data to say that it's safe. There were some animal studies at 2.5 times the dose we see in humans that showed some genotoxic side effects, but we don't have human data to really say that there's adverse effects. And we also have pretty large cohort studies of kidney male transplant recipients who were taking mycophenolate as part of their immunosuppression regimen, who fathered children compared to those that were not on mycophenolate. And there was no significant differences in birth outcomes of those children. So we do have a lot of reports of males on mycophenolate and no increased adverse effects of those babies. So in my clinical practice as a transplant pharmacist, I still let my male transplant recipients know of that warning because it is in that package insert, and it's kind of just a risk versus benefit discussion with them and kind of laying it all out there for them to make that decision and encouraging them to talk to their transplant provider once they start family planning.
Yep. And some of that data is from the Transplant Pregnancy Registry, and we've really found no issues with men fathering children on mycophenolate and any increase in miscarriages or birth defects. So I know it was very interesting. We had a lot of questions about in vitro fertilization. So Sylvie, I'm going to go to you next because I think we have some information. If you could just kind of briefly summarize, IVF in our transplant recipients.
Yes, sure. Thanks, Lisa, for the question. And this is actually one of the very often question which is asked by my patients as well in the clinic. I'm a kidney transplant physician. And unfortunately, there was not a lot of data in the past, just mostly reports from single centers. And that kind of motivated us to do this study, which was done in collaboration with the Transplant Pregnancy Registry. And Lisa is the senior author in the study. And what we looked at was 130 pregnancies in kidney transplant patients using assisted reproductive technology and compared it to natural conception pregnancies in kidney transplant patients. And we compared the fetal and maternal outcomes and graft outcomes. And what the study showed was that the risk of live birth does not differ in the two groups. So ART, assisted reproductive technology, or IVF, does not reduce the risk of live births. The rate of graft failure was not different in the two groups, so the IVF did not impact that as well. However, we did see that IVF or assisted reproductive technology did have some higher risk of preterm births, slightly higher risk of cesarean sections, slightly higher risk of lower mean birth weight babies and lower gestation age of babies as compared to natural conception pregnancies and kidney transplant recipients. However, just to we have discussed this briefly in the webinar as well. So transplant does increase the risk of preterm births. It does increase the risk of cesarean section as well. So we do have a lot of data showing that. And actually, what this study is saying is that ART or IVF may increase the risk a little bit further. However, what is encouraging is that the live birth rate is still similar. So that's what I tell my patients, that overall the pregnancy is going to do well. Overall, the graft is going to do well. But we do have to remember that majority of these studies, which looks at pregnancies in transplant patients, we do assume that the risk factors are not there, like the creatinine is stable to start with, 1.4 or less. They did not have recent episodes of rejection. They were on optimal immunosuppression, as we discussed, ensuring cell-septor mycophenolate was changed to azathioprine, and blood pressure was well controlled. So that counseling again is very important for our patients, that we do say the graft failure may not differ, but we also have to make sure that the risk factors are not there when they decide to, when we have a shared decision making with our patients with regards to conception.
Yeah, that's a great point. And I think we did a similar study with IVF and liver recipients too. We haven't looked at it in our non-abdominal organ recipients, but overall, we have not had reports of patients having major problems when using assisted reproductive technologies. So I think that's very encouraging for everybody. Carly, I'm going to go to you next because you have a little bit, I think, different, area of expertise, and it's a little bit different for our thoracic patients. But can you just kind of, give us some thoughts about pregnancy after either heart or lung transplant?
Yeah, I mean, I think that, what we've seen from the data in our transplant practices are that pregnancy after thoracic organ transplantation is riskier compared to other organ transplants. But there've still been many patients who've successfully had pregnancies. I think the things that we think about are a longer period of stability in, for my patients, lung function. And also, particularly in lung transplant, we often maintain our patients on triple immunosuppression. So this issue with the mycophenolate mofetil and needing to change to azathioprine is particularly important. And then I think also specific to lung transplant, the point that Joelle brought up about community-acquired respiratory viruses after transplant, these are much riskier for our patients. So many times, and most of my patients are older, but we can see a lot of rejection episodes triggered by interaction with children or other people due to viruses. So this is an important thing that we need to counsel about.
I think that leads perfectly into my next question for Shweta. We know that transplant patients are at increased risk for infection. And are there anything additional precautions that pregnant recipients might need to take, or any other kind of special recommendations prior to pregnancy from an infectious disease standpoint?
Hi, Lisa. Yes, thanks for that question. I think with pregnant transplant recipients, the best course of action is prevention. Because, as we know, that if they get an infection, there is concern of not only infection for the mother, but transmission to the baby, which is something we absolutely want to avoid. In that scenario, we reiterate the instructions we give to all transplant recipients, the personal hygiene, hand washing, wear a mask during respiratory viral season. When it comes to food, I think the restrictions are stricter, like, avoid any raw food, avoid unpasteurized milk, cheeses, soft cheeses for the risk of transmission for listeria. Um, and with vaccines, they have to be careful with the timing of the vaccines. So I think most of the vaccines, the highest risk is whooping cough or diphtheria, mostly because infants have severe illness. So it is better to vaccinate the mother. So Tdap is recommended, the flu vaccine, RSV vaccine. Most of these are recommended in the third trimester, but it can be given a little early, maybe closer to 27, 28 weeks. Especially if it's in the middle of like peak respiratory, season, or if it's flu season. What I did want to say is that there is just one RSV vaccine that is approved for pregnant women. So if you are going to a pharmacy to get it, ask for the Pfizer or Bristol vaccine. The other two are not approved for pregnant women. And that is 80% effective at preventing severe RSV in the infant. So I highly recommend that.
Great, thank you so much. I think overall, it's just important for our transplant recipients to be aware of how they can decrease their risk for infection. So we had one question come in on the question and answer, and it says, what complications can happen if pregnancy does not happen or does happen within a year of transplant? And what we've seen is that sometimes patients can have more transplant problems during their pregnancy, and they can deliver a little bit earlier. And a lot of times in that first year, if it's an unintended pregnancy, patients are on mycophenolate. So there could be mycophenolate exposure during that pregnancy as well. So it's not necessarily that you're going to have complications, but because patients are still on more immunosuppression during that first year, and there could be other complications. So it's just more of a best practice, not necessarily that these complications are going to happen. But if you think about it, we start patients on more immunosuppression that first year after transplant. You're at higher risk for rejection. So it's really important to just not get pregnant in that first year if possible. And also, just as a follow-up, Elizabeth, regarding the mycophenolate, I don't think you said it was teratogenic, but just because it can be teratogenic like we don't want to have patients breastfeeding while on mycophenolate because we just really don't know about what can happen. And I think that's what I've seen in the registry too, is that we really just haven't seen a lot of people breastfeed on mycophenolate, so we don't know the outcomes. And it's not recommended in the package insert either to breastfeed while on mycophenolate. So I think that's where that comes from. And thank you for answering that in the chat also. I appreciate it. What are your, oh, here's a one that I get all the time. What are your thoughts on the need or lack thereof of holding MMF before egg harvesting for IVF? I have an answer for it, but I didn't know if anyone else on the panel has ever had this question asked of them. We have had patients do harvesting for egg retrieval on mycophenolate. What we've seen is no problems in the patients that reported having a surrogate and staying on their mycophenolate during egg harvest, because we really feel like the mycophenolate causes or the malformations and the birth defects happen during pregnancy. So it really doesn't necessarily affect the eggs that are just in the person. So that's one other avenue that we really haven't seen those problems. Another question that we had ahead of time is about belatacept. On the recording, we said we don't have enough information. In the transplant pregnancy registry, we have about 25 pregnancies, and all of those outcomes, there were 20 live births, and we saw no increase or we saw no birth defects in those infants where the mom was on belatacept during the pregnancy. So it's something that, we can look at and the registry, and we did not see any problems with that medication so far. But it's not as many outcomes as that we've seen with some of the other medications. So we're still kind of, feeling our way through that one until we get more outcomes. Another question I think that many people might have is about rejection during pregnancy and how you might consider treating a rejection during pregnancy. Does any of our panelists have any experience with it or want to share their thoughts or what they've done? Sylvie, go ahead.
Yeah, sure. So I think one of the challenges is diagnosis of rejection during pregnancy. So that's what, I have seen in my practice, because whether it is the worsening of creatinine is occurring due to maybe possible preeclampsia, or it is just, there are a lot of other causes of AKI during pregnancy. So just to differentiate it with rejection is challenging. At the same time, the other challenge which I've faced is use of cell-free DNA, which we increasingly use nowadays to not diagnose, but it's a sort of a screening test, non-invasive, which can tell us whether there is a high likelihood of rejection or not. But we are not able to use that in pregnancy because it's really not validated so far. Now, I know there have been talks about doing studies in pregnant patients, but as far, it's still not validated. So the only way to diagnose it is biopsy. And now that becomes another consideration, because it just depends how far we are in the pregnancy. Because as the literature says, it is safe to biopsy till 24, 26 weeks. Usually, and if it's in the third trimester, most of the times the recommendation is to do an early delivery and then do biopsy after delivery. But again, these are all best practices. So the decision is always very much individualized depending upon the patient and with a shared decision making. And the treatment options again are very limited, because most of the times we are able to use steroids. And that's what I have done in my practice. Couple of times we have treated rejection empirically. If it was far in the pregnancy, especially in the third trimester, we just did some pulse steroids. Because the other treatment, for example, thymoglobulin, or if we are treating for an antibody mediated rejection, which again, the protocol differs by each center, is usually not safe in pregnancy. So the concise answer is biopsy is challenging. We can use steroids to treat rejection in pregnancy, and we can sometimes treat empirically if the suspicion is high.
Thank you so much. Elizabeth, I've had another question about men, which is great because I always think that patients don't think they can participate in a pregnancy registry because they're a man. But do you have any recommendations about counseling male recipients that are on an mTOR inhibitor like rapamycin or Zortress and contemplating fatherhood?
Yes, so mTOR for females is usually the probably safe, but kind of like a risk versus benefit discussion. I'm not aware of any definitive data saying that men should not be on mTORs and father a child. So typically that's not something that I usually warn my male recipients that they should refrain from fathering a child. If it does come up, again, it's just more of a risk versus benefit discussion, but really there's no convincing data to say that it would have a harmful effect.
Yeah, and I think early on there were some studies showing that it decreased spermatogenesis. So it might be something to look at if someone's, we've definitely had patients father pregnancies on rapamycin or rapamune and sirolimus. So I think it's just something that if they're having trouble conceiving, you might need to look into a little bit further if that might be causing some problems with fertility. It's really hard for us to study fertility in male patients because we just don't know of those who aren't able to conceive. So it's definitely something that I think still requires more study and more outcomes as well. So I'm looking through some of our other questions here. Yes, the cell-free DNA can come from the fetus too, so that's why it's really hard to really use that as the definitive test during pregnancy. There's been a couple of abstracts that were presented at the American Transplant Congress looking at cell-free DNA during pregnancy. And I think there's a way that they can distinguish between, because you're talking about three different or four different things then, because you have the three: transplant, the patient, and the fetus. So it's a little bit more complicated when using that test during pregnancy. We talked about, does anyone have any thoughts about dosing during pregnancy for the CNIs for either tacrolimus or mostly tacrolimus? And I'll ask Joelle to start with first. Do you remember if your tacrolimus increased during your pregnancy?
I actually didn't have any increases during pregnancy. I think my levels stayed exactly where they wanted them to. I know with the blood volume increases, a lot of patients do have increases. I didn't, but again, I think they were watching those levels really closely. And it was recommended after I delivered because I was having just a little bit of fluctuation in my levels overall. My blood levels for everything else didn't change, but they did want me to up it for a little bit and then it came back down. So not during pregnancy, but after I delivered.
Yeah.
I can answer that too. With during pregnancy, some of the physiological changes, we see a decrease in albumin, and the calcineurin inhibitors are highly protein bound. So we have more free drug in the patient's body, especially in that third trimester. And also we have increased liver perfusion and an increase of our CYP enzymes or drug enzymes that metabolize CNIs, tacrolimus, and cyclosporin. So in that third trimester, sometimes you need to go up on the total daily dose by like 20 to 30%, but really keeping in mind that disproportionately, you're going to have an increase in unbound active tacrolimus in the recipient system. So that could be more toxic side effects, even though that whole blood concentration goal is the same. So really close monitoring of tacrolimus is what we usually recommend. And looking out for things like neurotoxicity and nephrotoxicity if you're having to increase the dose to maintain your goal.
And it goes perfectly into this next question that we asked. Do centers routinely check free fraction tacrolimus to help guide tacrolimus management during pregnancy? And I would say the short answer is no. I don't know of many centers that are checking for that. I think they just use a regular trough level during pregnancy. So I have not heard that routinely. But there's a lot of, I think, potential studies looking at what the levels during pregnancy look like, and if, you know, it is being increased, you know, where's that, you know, tacrolimus going? I also had another question for you, Joelle. Let me see. Oh, here we go. What kind of support, medical or personal, felt most crucial to you during your pregnancy? Like, was there one thing that, you know, that really helped you?
So I did just
You-
answer this in the chat,
Yeah.
but I think
Mm.
medically the thing that felt most crucial for me was I had a female transplant doctor who was a mom, and who was kind of like guiding me through the process while also being very accessible to me via email, because throughout my life I've had a lot of health anxiety. So of course I wasn't emailing her every day, but if I had a question that felt pertinent, it was nice to be able to have that kind of lifeline to her to say, you know, I have this question, this doctor said this, what should I do? So that was really crucial. Personally, I think just knowing recipients and other people that had gone through pregnancy and were moms, because just having like mom friends or pregnant friends at the same time was really crucial. And just having a husband that understood like my, you know, just a supportive husband that understood like my medical history and my anxieties and just everything, you know, just that would rub my feet at the end of the day, you know, that was also very crucial too. So yeah, all of those things were helped get me through for sure.
Oh, that's awesome. Sylvie, I think, you know, there's a question about preeclampsia and aspirin use. Can you just comment about that as well?
Oh yeah, so all kidney transplant recipients or any patients with chronic kidney disease, even if they have other solid organ transplant, are at high risk of preeclampsia. And the only way to show, only intervention which has shown to reduce the risk of preeclampsia is aspirin, which should be started at the end of first trimester. We can either use the regular dose or 162, it just varies. But I think what we should be cognizant about as providers and as patients is if there is if the patient is at high risk of preeclampsia, they should be started on aspirin at the end of first trimester. And all kidney transplant patients are at high risk of preeclampsia, and all chronic kidney disease patients are at high risk of preeclampsia with other solid organ transplants.
Great. Thank you so much, because I know that's something, you know, that we recommend nowadays, that everybody start on the aspirin around the second trimester. Let's see here. We had a couple other questions that I'd like to, oh, I know. This was the one, how many children can you have after your transplant? We have some data from the Transplant Pregnancy Registry looking at subsequent pregnancies, as I call them. So someone who has more than one pregnancy after their transplant. And I think the key to having another pregnancy is stable transplant function. So you really want to look at to see how your transplant's doing. Are you on medications that are safe? How do you have hypertension still? Do you have diabetes? Or is there anything else that could affect a pregnancy? So usually if you have that good stable transplant function, you can have another child as well. So that's something that we do see in our transplant patients. We're kind of almost at the top of the hour, but I didn't know if any of our panelists had just kind of like a anything they'd like to add from what they've had in their experience, or if there's anything else that you feel like we should touch on in the next few minutes.
So I just had one comment to make, and it was mostly on the tacrolimus dosing, I think, which we briefly talked about. So the classic literature does show it may need an increase of 20 to 30% dosing, but I really wanted to emphasize this, that there have been a lot of cases of tacrolimus toxicity, especially, reported from my colleagues outside US, especially in Australia and Canada, where they have done like a lot of tighter trough controls. And as we discussed, it is the unbound and the free tacrolimus, which is usually the one, and that is not usually measured. It is usually only measured in research settings. So what I've seen in my practice is that actually all of my patients have not required increase in their tacrolimus dose during pregnancy, and this was shared by Joelle as well. And I usually do a very broad range, mostly like 4 to 8, and the patients have done well. So just something to be cognizant about, like if a dose increase is needed, just be cautious about it, because in the usual practice we haven't been feeling the need, we haven't been increasing the dose what has been classically taught in literature.
Great, thanks so much. Joelle, any other final kind of thoughts about your journey and pearls of wisdom from someone who's been through it?
I don't know about the whole journey. It's definitely been an amazing journey, and just something that like I'm very happy to have had the resources from the Transplant Pregnancy Registry, as well as other transplant recipients that have had children. This has actually been super informative for me, because, as my son is getting older, and we have been thinking about like maybe another one, but probably not. My doctors have been, I have a lot of, just a side note, I have a lot of scar tissue, so they are very, very hesitant for me. But it's been such a blessing to be a mom. It's been such a blessing to have him, even when he wakes me up at 3 o'clock in the morning. The journey's just been such a blessing, and I'm very, I'm in awe of all of these amazing women that are here and speaking about this. And you guys are what make it possible for us to feel comfortable and confident to go through this journey. So thank you all so much too.
Thank you, Joelle. That was wonderful. Shweta, Carly, or Elizabeth, any other final thoughts or pearls of wisdom from?
The only thing I was going to say, Lisa, is maybe, folks can reach out if they have questions after the webinar, if there's anything. I know we only have this hour, but any of us are searchable in the AST directory, and we'd be happy to answer any lingering questions.
I'm just going to jump in and say that it's not just during pregnancy, but I think postpartum and after that, like Joelle was saying, if you have other children, toddlers, infants in the house, especially children going to daycare, there is a risk of getting viral infections from them, and those will linger for a very long time. And if you're pregnant and there's a daycare going toddler in the house, be wary of hand, foot, and mouth, because, pregnant women have mild infection, but it can get transmitted to the fetus, and then there's growth retardation in preterm labor. So you still have to be careful if you have another baby or toddler in the house.
Great. Thank you so much, Sweta. Elizabeth, any?
Just thinking about medications, looking over, sometimes we hyper focus on immunosuppression, making sure we're looking at all their medications. There's some antihypertensive medications, hyperlipidemia medications to be avoided. And if they're on some of those new diabetic medications, we might want to switch them to insulin. So just looking at the patient as a whole, and it with the team of transplant providers and the MFM.
That's a great point, because it's not necessarily just the immunosuppression that our patients are taking. So there could be a wide range of medications that they need to have looked at prior to a pregnancy, and maybe switched as well. So not just the immunosuppression. But I think as we reach the top of the hour, I really want to thank the audience for the incredible engagement. We had enough questions to keep us going for the whole hour ahead of time, and then the few that were added during the webinar. And I'd really like to express my deep appreciation to Joelle, Carly, Elizabeth, Sylvie, and Shweta for their time today. Joelle, it's been wonderful working with you on these webinars, and I'm so happy that we've gotten to meet and, kind of help you with your journey to parenthood as well. So at this time, I'll send it back over to Brian for some closing comments and our finishing this up.
Thank you so much. AST and Power to Save would like to extend a heartfelt thank you to Joelle for sharing her transplant story with us today, Lisa for moderating our session, our incredible panelists, and all of our attendees. AST and Power to Save would also like to thank Eurofins for their generous support of the session. In about a week, you will receive an email from Zoom Webinar with access to a free on-demand recording of today's session. Before you go, remember, when the webinar closes down, you will see a short evaluation survey to complete. Please take a moment to complete that survey to help us keep our content current and engaging. Thank you all again for today's excellent session.